Thank you for all for being here and get together so we can share our knowledge together about medicine and obviously improve and strengthening our relationship as friends and colleagues. And obviously, we call the beautiful moments we were young, but we are still pretty young. Okay, so thank you to Dr. Yan and Dr. Wan. So today I'm going to talk about brain tumor therapies. This is a totally different topic, but it's a very important topic. I know most of you probably don't know the new development in brain tumor therapies. My slides ready? I'm not sure. So basically, you probably all knew that many celebrities diagnosed with brain cancers. Recently, it's John McCain, unfortunately, with glioblastoma. And then before that, Joe Biden's son, Beau Biden, he died from glioblastoma. And before that, Ted Kennedy from Massachusetts, he died from GBM or glioblastoma. So those are challenging, this is a challenging disease, and many celebrities diagnosed with this, and obviously they increase public awareness, because most of our patients, when we were diagnosed with brain tumors or GBM, they never heard about this diagnosis at all before. They all really literally shocked when I tell them the pathology. And obviously there is a long process of recovery from that mental shock. They disbelieve and obviously recover, and then the next is moving forward with treatment. Okay, so I'm still waiting for my slide to get started. Basically, what I'm going to share with you about what I do in terms of taking care of patients with glioblastoma, and what's new on the block that you should probably know, at least know some of the concepts. Your patient is going to bring those things to your clinic when they see you as a primary care physicians or cardiologists or neurologists and rehab doctors. So brain tumor, unfortunately, it's not very prevalent, as you all know. Not as frequent as breast cancer or lung cancer. So where is the control for the, here. So with as a part of CME requirements, after we discussing the topic today, you should know some of the basic elements of knowledge. So in terms of disclosures, I don't have any personal disclosures. I have bring a lot of trial to our institution, UT, and also Memorial Hermann, for conducting clinical trials in our institution. So this is what we're going to talk about: how to achieve diagnosis of malignant glioma, and then what's the treatment options, both for newly diagnosed GBM or glioblastoma. And also for recurrent, because they all bound to recur. It's just a matter of time. And obviously, what's the new clinical trial results, as well as what's the future directions? What's the promise? What's lie ahead for me as a neuro-oncologist, and obviously for clinicians in general, and for our patients in terms of hope. So as I said, GBM is not as frequent, fortunately. It's only 15,000 per year in the US. And obviously, brain metastasis is a lot more prevalent. So what's the overall survival for those conditions? GBM, as you see on the bottom, is 14.6 months. From the time of diagnosis to death. For example, Ted Kennedy, even though obviously we want him the best, and he did get the best. But with the best, he was in MGH, and he went to Duke. At one time, he had 7 neuro-oncologists in his room. And his overall survival, unfortunately, is 15 months, 1-5, and he died. And Joe Biden's son, Beau Biden, he is younger, Attorney General from Delaware. I think about 40, 45 years old. He died at 2 years. While getting treatment from MD Anderson. And obviously wish the best for John McCain. But there's actually a lot of patients out there facing the same challenge. That is, we really should have some better therapies as we treating patients for decades with brain tumors. We have not improved as much compared to other cancers. And then for other brain tumors, which is like a low-grade glioma or astrocytoma, it depends on the type. There is another type called an oligodendroglioma, which is a better prognostic type. I will not be able to mention that here because my main topic here is GBM. And for actually oligodendroglioma, they can live like 10 years or 15 years. And then for astrocytoma, it's about, depending on the patient's age and obviously the tumor location and the surgery or not, or resection. We call it debulking or gross total resection. It depends on tumor location. Sometimes the surgeon cannot remove as much as we would like. So the variability is quite large and can be 5 to 8 years. And for anaplastic astrocytoma, which is the WHO grade 3, the WHO is the World Health Organization, it's 2 to 3 years. Again, it varies quite a bit from patient to patient. So we really want to maximize their factors in terms of control of the disease, while allow them to have really a good quality of life along the way. So for GBM, as we just said, it's really the most aggressive or malignant brain tumor. It's called grade 4, and it occurs peak in about 65 years old. Now actually our longevity increased to, for male, for example, 80 years old, for female, 85, 87 years old. So the GBM occurs slightly increased in terms of the peak. So 65 now used to be 55 to 65. And then, as I said, they really, even with treatment, it still recurs. So that's really the challenge we all face. The patients frequently, what's the point of getting all the treatment? Radiation and chemo still recurs, so the treatment does not work anyway. Obviously, we tell them it is worse, but it's not good enough. So if you don't get treatment, the tumor grow back in 2 or 3 months, they die in 3 months. So that's the reality. And as I mentioned, the median overall survival is 14.6 months. That's actually for patients with clinical trials. That's all reported for the different trials. That the most common number is quoted is 14.6 months. Actually, we just did population-based studies of using the SEER, that's the oncology brain tumor database. We found that if you go back in 10 years, the median overall survival for all comers, GBM, is actually 8 months. So now, with better therapies, it's 11 months. So it's better, but it's still not as good as you see. And then for the clinical trial group, is actually a better selected group, as you all know. Patient can be in the trial. Any of the study, cardiology or neurology, is a better selected crowd. So the same case here. And so how achieve diagnosis? This one is actually pretty straightforward. History, physical exam, and the most important is imaging. Once you see the MRI, pretty much 99% of the time we are correct in terms of GBM. Obviously, there's always 1 or 2% that we could be wrong. That could be a metastasis or lymphoma, or those rare conditions. And obviously surgery, and then pathologists give us a definitive diagnosis of GBM. So the imaging looks like this. And if you see imaging like that, the first one is the T1 without contrast. So the first one is, because I'm not sure you all see MRI very often, probably not. So I want to educate everybody so we're all on the same page. So this is a T1 without contrast. And then this is called a FLAIR. This is a T2 scan, but it's fluid attenuation inversion recovery. So the name is a synonym. It's not the flare up we use in the Chinese, in the English language. And then this is the with contrast. Both are the same, different cuts. So if you see something like this, and that's called irregular enhancement, and that's very signature for GBM. As I said, 99% of the time you are correct if you see that. But there's always 1 or 2% chance of something else. So we don't want to miss that. So we don't really want to jump to that conclusion when we talk to patients. We said it's always likely, but not definitive, until pathology is bad. So the next slide is the pathology slide that once the tissue is removed, pathologist has that. Let me see, I can control that. So that so you can see this is is called a necrosis, this area. And then there is a new vessel this is the new vessel we call angiogenesis. And with those features, the pathologist would tell you this is GBM or glioblastoma. And nowadays, we have even molecular stuff that's part of the pathology report, like EGFR, p53, and which is getting more and more common as part of the report of neuropathologists. So obviously, the number one step, once you see that imaging or patient present to the hospital, is surgery or neurosurgery. In general, if possible, if you want your patient to be done by a tumor neurosurgeon, there's obviously, the neurosurgery is a general specialty. You want them, whoever has done a lot of tumor surgeries to do this, because there's a lot of variabilities, and because obviously we don't want to do any harm. But with that condition, and some surgeons can be more conservative, others a little more aggressive. But if you are more aggressive, obviously you can cause harm. But in the experienced hands or tumor neurosurgeons, they can do a good job without giving patient actually harm. So that's where the art lies. So in general, you want somebody have done a lot of this to do the surgery. So obviously the surgery can reduce the mass effects and improve patient's neurological condition right away, and then give the histology diagnosis by a pathologist. As I said, with surgery alone, only three months or so, and then if you don't do anything, the tumor grows right back, and obviously the patient gets impairment and they may die very quickly. So it's really not a curable condition. So the question is why? Because we can see that on the MRI. If they remove everything, the surgeon usually say, "Oh, remove everything," but they remove everything they can see. That's the qualified statement. And if you don't use that word to patient assume they are getting cured, because number one, they never heard about the diagnosis. And the surgeon said, "Oh, I remove everything." Then the question is, why do I need to see anybody else anymore, right? So that we had to do a lot of explanation to patient that the MRI is what we can see, but there's tumor cells in the area that we cannot see with MRI. And then if you don't get treatment, obviously the tumor will grow right back, and then patient will get impairment. So this is the example of ring-enhancing lesions. And then the surgeon actually removed as much as possible. As you see, this is a surgical hole right here. But there's still residual disease. Then the question, why don't they remove that? As a neurologist, you will see, if you remove more of that, the patient is going to have more impairment. Right now, this patient is, we call it alaxia without agraphia. What that means is the patient can write, but cannot read. And they also obviously have a peripheral vision deficit. So that's all this patient has. So it's a neurological deficit, but it's expected, and also they already have a deficit before the surgery. So it's not the surgery causing the deficit, but it's the tumor. But the surgeon don't want to introduce new deficit. So that's where the art is. That's where the challenge is. And so we want to minimize those deficits, obviously maximize quality of life. So this is the diagrammatic description of the tumor, and so this is the enhancement part of this. And then this is the flare. This is the flare part that's corresponding to here. And then this is a little bit off. I actually repositioned, but we got the older slides, but that's okay. And then so this is what we see the tumor, and then this is the flare, we call it edema or swelling. But actually there is tumor in this area as well. And actually tumors in here and in here. It's just a reduced density. Obviously we cannot remove all of that for pathological examination. But we have done autopsies, or other colleagues in the field have shown that there is always tumor cells in this area. It's just that with reduced density. So in other words, surgery alone is impossible to cure this disease. So how to achieve the best management for patient? As you can see, it's really a team approach. One specialty is really not enough. Neurosurgery is not enough, and then neuro-oncology alone is not enough. You need a radiation oncologist as well. So we have a team of doctors work together Many of the specialties, as you see, is working behind the scenes, such as neuropathologists, neuroradiologists. Patients don't know them, but we have obviously discussed together, and we have a tumor board every week to discuss those challenging cases. And also nowadays, we need a social worker, and also with the molecular biology, we need a research scientist to work with us to interpret those, like we call it precision medicine results, the next generation sequencing information, and what that means, and what therapies we choose in addition to the standard of care. So, as I mentioned, the treatment is maximize safe resection, and hopefully in the experienced hand. That's why it's usually the tertiary medical center is better by default. And obviously in China, as you already know, that's like the Tiantan Hospital is the most popular surgical hospital for brain cancers. And then the other treatment after patient recover from surgery, usually about 2 or 3 weeks from surgery, we started radiation. XRT is radiation. And also the chemo drug is called a temozolomide, or the brand name is called a Temodar. This is concurrent for 6 weeks. So they get the treatment every day, except weekends or holidays. So it's 6 weeks, 30 visits to the radiation oncologist facility. And at the same time, they take the temozolomide. This is an oral drug, so fortunately it's not IV, so you don't need an office. They can just take it at home. But this one, you take it including weekends. So this is concurrent for 6 weeks. And then you do it temozolomide alone, 5 days on, 23 days off, which is total of 28 days, for a total of 6 cycles in Europe, and then 12 cycles in USA. This is, as you can see, is arbitrary, because the trial was done by arbitrary cutoff of 6 months. So I'm sorry, here is 6 months, not 6 weeks. This is 6 months, this is 6 weeks. So and then in the US it's 12 months, because we feel the longer is better. Obviously, there's side effects with the chemotherapy, but fortunately, the side effects are actually very much tolerable. So this is a famous paper that's Jay Zhu. He actually from Switzerland, but now he's recruited to Chicago. So Chicago got a start here, just like probably 6 months ago. Anyway, so from this trial, it's a big deal. This is about 700 patients. It's a multi-international trial. It's like the whole Europe, Canada together for this trial to carry out. USA was not. USA was an independent, relatively competing group. There's another trial was done. Anyway, so with this trial, it's done obviously, as you see, the published in New Journal of Medicine paper, that 2005. So since then, all the treatment is concurrent. Before this was radiation first, and then temozolomide later. So this is the schedule, as I just told you. So they choose the 6 months as a cutoff. As I said, fortunately in USA, we are able to do a 12-month. There is no scientific data to supporting 12 months is better than 6 months, but from our kind of a collective wisdom or gut feeling, we think 12 months is better than 6 months. And then some of our patients actually refuse to stop. And we actually treating patients for like 3 years, 4 years with temozolomide, because they tolerate so well, and they don't want that the tumor have a chance to come back. Obviously, it's a judgmental call. We could not back that up statement with scientific data. But in general, the good news is patients tolerate quite well. So this is the data that from that trial with treatment, concurrent treatment. This is the curve. So they live 14.6 months intermediate overall survival. That's TMZ, the temozolomide with radiation. And then the previous was radiation alone, followed by temozolomide. So it's not a huge improvement, but because the overall survival is so short, so even 2 months better is statistically significant. So since then, everybody is doing this concurrent treatment. And obviously, the next question is, why some patients die so early? Some are longer-term survivors. that's always part of the scientific investigation. There is an individuality, and there is a gene changes that's different from patient to patient. So actually, there is a gene that's been found from that group. As also Jay Zhu as a senior author, but this Peggy is first of all, this whole team from the scientific perspective study those patients and tissue. They find this particular gene that's important, called MGMT, methylguanine methyltransferase. It's a basically repair enzyme we all have. And then if that enzyme is active, they actually repair the damage temozolomide and the radiation causes. Then the tumor would allow to continue to grow. So with that gene present, the patient is not doing so good. And then how to shut down that gene? Actually, it's the methylation. As you all know, methylated promoters, usually the gene is silent, although not every gene is that, but the majority of genes is regulated that way. So with MGMT methylated, the patient is doing better. So this is one of the prognostic factors we know. And now we know more of that from the next generation sequencing. Specifically, IDH1 is another gene called isocitrate dehydrogenase. With that mutation, actually, the patient doing better as well. I'll talk that briefly next. So with that separation from the methylation versus non-methylation, the patient can do a lot better with the methylated plus concurrent treatment of radiation temozolomide versus without methylation, and then if you do it the traditional way, or the radiation first, and then so there's a huge difference. So therefore, all the patients in 2005, we do a concurrent radiation temozolomide, and also MGMT is an important prognostic factor. We do that as a standard of care, but even getting that assay to be carried out accurately and reproducibly is quite challenging. So some of the centers do not do the MGMT test, but patients may ask those things. What's my MGMT status? The other question is, with MGMT methylation or without, the treatment is the same. So it's not really changing treatment yet, because we don't have an alternative drug than temozolomide. So what's the treatment options for recurrent GBM? As I said, all the tumors are bound to recur, it's just a matter of time. The most common recurrence period is about 6 months to 8 months. So it's very quickly. That's that's part of our job. It's really busy because the patient have MRI changes. You gotta have a next plan ready. You don't have a lot of luxury of time wait around. So at this juncture, the secondary treatment when tumor recurs varies from hospital to hospital, actually from neuro-oncologist to neuro-oncologist, because there's no standard out there. But the common standard is, if possible, we'll do a second surgery. Again, depending on the tumor location, on the patient status, and also the surgeon, how comfortable they can remove some of those areas that's challenging. And the second is, if possible, we have called a BCAU wafer. It's an orlomuscin wafer. The brand name is called a gliadol wafer. You can put it in the surgical cavity, which I have a slice to that. And stereotactic radiosurgery, or gamma knife, or cyber knife, many of those can be used in junction to that. Or if the surgery is not possible, we just do that SRS only to kill the fast-growing part of the tumor. And then we have additional chemotherapy called bevacizumab. That's this one. The brand name is called Avastin. And with or without irinotecan. So this bevacizumab is angiogenesis inhibitor, namely reduce new vessel formation. So you can imagine, by doing that, you can starve the tumor from nutrition. And then the irinotecan is top isomerase inhibitor to prevent effective DNA replication. And obviously, if the institution have clinical trials, patients would have more options. But as you can imagine, not every patient are eligible for clinical trials. And finally, I would say combination of all the above is the best. So this is the gliadol wafer. or lomustine. That there's another name called carmustine. So they put the drug in the basically the implanted into that pill, and then that pill is or not pill, just wafer, put in the surgical cavity. After right at the OR when the surgery was done at the same time in that wall, so that the drug can slowly release. Yes, this doesn't work, so you can control it for me. So to the next slide, slow release to the surrounding area, and then as a chemotherapy local. And then next slide. So with that wafer versus without wafer, again, it's not a huge improvement either. It's about 2 months difference. And this is for recurrent GBM trial that showing that difference. And the next slide is for newly diagnosed GBM. If they can do that frequently, as you know, for newly diagnosed GBM, you really don't have a lot of time because the patient coming to the ER and do surgery, and then the wafer, it has to be on standby. Frequently, the hospital does not have it. So if you order it and get it shipped, it's too late. And then also that in the OR, the surgeon will not know this is GBM or not, even though we're pretty sure it is most of the time. But since we don't have pathology, you don't want to jump to that, be definitive, unless you have a frozen diagnosis, like the pathologist next door tell you from the frozen tissue that this is GBM for sure. Usually depends on the pathologist as well. They may not be as affirmative for you, so they just reluctantly tell you this is malignant neoplasm. That's it. So you really cannot jump to that. What if it's not GBM? Then you put the wafer in, then it may be a malpractice. So that's the reason that little wafer is not placed at the first time around. And also the cost is about $10,000 for that, like 8 to 12 pieces. And then if you put it in, the hospital may not get it reimbursed, as you know, the DRG policies. So there's a lot of logistic and political and also financial reasons. But anyway, from a medical perspective, with wafer is definitely better. And then in general, the surgeon has to be aware of some of the side effects with the wafer. Is number one is the surgical cavity cannot be communicated with the ventricles, because in that case the wafer might floating around causing obstruction. And number two is the wound healing has to be a little bit better closure, because with the wafer the wound healing can be sometimes delayed. Sometimes it's delayed wound healing that people obviously have delayed everything else. Sometimes the infection have an increased risk as well. So now let's move forward to the angiogenesis inhibitor, which is bevacizumab, or the brand name is called Avastin. You probably all heard about this, maybe 10 years ago, that when this first developed. It's very exciting, and we hope that was actually an effective treatment for GBM, which was true for the short period of time. So with this drug, as you see the next slide, the patient is doing better. As I said, bevacizumab is an angiogenesis inhibitor, so it's basically an antibody, binds to VEGF. It's a monoclonal antibody by VEGF, and that's developed by Genentech, and then that's why Genentech is such a successful company, because people are using that in all different cancers. So how we do that is 10 milligrams every kilogram IV every 2 weeks. This trial was first done in Duke on 32 patients with GBM and without, and with anaplastic or grade 3 gliomas. So with that treatment, as you see, the next slide is the tumor. This is the tumor that's at the recurrence. And then this is with treatment. And this is just a coronal view of the same patient, the same tumor. So that's, this kind of pictures is really exciting. We don't really see that in brain tumor therapy. So at the time, really like this, we use that like a water. When patients have progressive, then you treat this. And then for the next slide. So this is the summary of that. as I said, 63% has a response, that's a response rate. And then 6 months progression-free survival, this is a PFS, is 43% for GBM, and then 59% for the anaplastic glioma. Let me give you some of the party lines. In neuro-oncology, if any drugs, early device, if you try that, and they give you 15% of 6 months progression-free survival, that's good. So this is 43%. So at that time, it's really exciting. We're all very excited about that. As you probably, some of you doing research probably know, Judah Folkman, who died, he was actually the father of angiogenesis. So he developed this himself with his colleagues in Children's Hospital at Boston for a long time. And then there's a lot of resistance from his colleagues that, oh, this is not that exciting. But he actually single-handed proved that angiogenesis is important, can really induce or stop tumor growth or slow down tumor growth or cancer growth in general. But anyway, so he died, unfortunately, he did not get a Nobel Prize. He actually was nominated, but did not get it. So with that numbers, obviously, people jump to the next level, which is clinical trials. So the toxicity of this angiogenesis is actually very well tolerated. At the time, they showed some hemorrhage, they showed some clot, like DVTs and PEs. But actually, as Archie was talking about, the brain tumor makes the patient hypercoagulable. So they are prone to have thrombosis anyway, with or without therapy. So with the concurrent therapy in addition, so sometimes it's very hard to tell it's from tumor, it's from treatment, or from both. So I think it's most likely from the tumor in general. It just happened during the trial, so they recorded as such. Some bleeding, some clots most often, and then proteinuria. They lose protein in the urine, and also hypertension, which is probably related to the angiogenesis inhibitor because affecting the kidney to some degree, because the kidney is very rich in vessels. So the next slide, showing the overall survival for that trial is 72 months, in 6 months. So this is really, as I said, that the time was really exciting, and then there's many, many trials that subsequently carried out. So FDA approved Avastin for recurrent GBM. So basically all the recurrent GBM have Avastin. But there's always a but. So I will talk to you, so next slide, showing the case that I was talking about. This patient from Boston. Let's go through it quickly. I don't want to go too much of the time. Let's go to the next slide. So this is the initial presentation, as you see. The irregular enhancement on the axial view or axial cut, and then this is the sagittal view for the same tumor, and then after surgery, this is again with before surgery, and then there's a mass effect, as you can see. Patient is symptomatic. This is a FLAIR or T2 image for the same tumor. You can see the more of a swelling and also part of the tumor infiltration in the surrounding area. And then the next slide shows the post-op. That's the surgical cavity I was talking about. There's still residual tumor. The next slide. And then tumor recurrence. As you can see, there's a recurrence. But again, we cannot be 100% sure based on MRI. That's another challenge we all face with our patient. When the MRI changes, and we share this to our patient every time because it's not always straightforward to interpret those. So because patients all get radiation, so radiation change can give similar appearance. And obviously tumor recurrence can give similar appearance. So sometimes you have to tell the patient the uncertainty of this. It could be tumor, it could be radiation change, or it could be both. And the patient obviously get puzzled. What are you guys doing? You cannot tell me straightforward what this is, which is true. It's very hard. And then this patient had a second surgery. And then the next slide, the pathology showed actually a mixed picture because there's always some radiation change. We call it necrosis, and there's always some new tumor. That's the frequent picture of that. Unfortunately, we cannot tell patients before the surgery was done. But anyway, so this patient get a little wafer. So you can see this little disc, like depending on how you cut it, and then in this case, it's just like a line. So you need the surgical cavity. And then afterwards, she get Avastin with the CPT-11. And I continue temozolomide. So I use this called a triple chemotherapy, which I found that works better, even though there's no clinical trials data to back me up. Because in this business, as you see, patients die very quickly if you don't treat them aggressively. So I actually, for young patients, relatively healthy, their bone marrow is good, I treat them aggressively. So this is after surgery, and then have been stable for a long time. This patient actually eventually died after 6 years from GBM. Yeah, she actually, when I moved from Boston to Houston, she actually came to Houston to see me. Because the tumor grew again. And then doctor had the same kind of discussions, tumor, radiation change, and then she trusts me so much, so she comes here to see me, and then we have another discussion. Anyway, so now let's talk about targeted molecular therapy. And this is the buzzwords after the Avastin. It's actually very exciting for a long time, and now obviously get even more exciting, especially in systemic cancers. We all understand the molecular pathway now with GBM. There's 2 different pathways generating GBM. One is the de novo GBM, which occurs about 65 years old. When they occur, they have GBM. And that's what the pictures I showed you. The other pathway is called a progressive or secondary GBM. If they started as low grade, grade 2 or then to grade 3, and then when later on they develop GBM. So this usually occurs in younger patients, about 20, 30, or even 40 years old. And then obviously when they start with a low grade, they have surgery, they're doing well, even when sometimes do the same treatment for anaplastic astrocytoma. That's why you saw the previous slides, that's both GBM and grade 3 are lumped together. We call them malignant glioma. So that malignant glioma, that term covers both grade 3 and grade 4. But the GBM is specifically equivalent to grade 4. And with this 2 different pathways, and then they have 2 different gene changes. And this is older slides. And now we knew that what's make a difference from the very beginning is the IDH1, isocitrate dehydrogenase. That enzyme change allows the tumor to start. And that with that mutation, the patient develops this kind of pathway. So the grade 2, 3, and 4. So the tumor is not growing as fast. But if they did not have that IDH1 mutation, or they have an alternative way of forming GBM, and those are like this. They have P10, they have P53, and the TER, that's a telomerase, changes early on. Then their GBM is more resistant to treatment and more aggressive. So the next slide, this is actually, again, older diagram and very simplified understanding of single transduction in GBM. Nowadays, we know this a lot, 10 times, 100 times more sophisticated. So the research has developed tremendously, but translation of that information to clinical practice is always lagging behind. And in this case, by my judgment, it's too much lagging behind, unfortunately. But with this information, industry and the research have developed a lot of drugs, we call it targeted drugs. The next slide is showing you that this is another simplified process of the EGFR single transduction, and then eventually causing, with the mutation, causing uninhibited proliferation. So that's we call it cancer or tumor. So next slide is, with this pathway understood, we developed a lot of drugs, such as sorafenib or P10 inhibitors called Afinitor. And then next slide. And next slide. So this is all the pathways, all the inhibitors we found. Next slide. It's actually quite exciting with this information. And then we tried it. Specifically, my ex-boss, Patrick Nguyen, Tracy Batchelor from Dana-Farber and MGH, many colleagues tried this in the institution of all the drugs. But the unfortunate results is none of them works with individual drugs. Next slide. We tried all of that individually.
to patients. Because they inhibit this pathway and then they inhibit this pathway. So we all very frustrated. A lot of the trials carry out, but the results are not really better. The next slide. So all those drugs are there. And then we know the signal pathway abnormalities collectively. But on the individual patients, it's very hard to understand everything, as you can imagine. Now we know the tumor, what we saw on the MRI, the irregular enhancement, is not just one, it's actually heterogeneous. So there is different gene changes in different parts of the same patient, same tumor. And then what we do in general is you get one piece of tissue to pathologist, or one piece of tissue to Foundation Medicine, or whatever your institution's research team. And the rest of it, we don't know. We just, either we don't have it, or it's in the peripheral block of pathology department. And to do a better assessment, you have to send as many pieces as possible for molecular studies. And who can afford that? And who has the resources to do that? Right now in the US, we can't afford that. Then insurance will not cover. So that's the reality. The next slide showing that is really individual drugs does not work, and which reflect the complexity of the tumor. Because we understand a lot, but not as much. And we have a lot of drugs, but we need a combination of drugs, or one drug that's able to have multiple targets, quote unquote, 30 drugs. That might be better, but we cannot find that magic bullet yet. So let's see the next slide. So this is my summary of that. We tried so many things, and then none of them worked so far. So what's new is this device. It's called a tumor treating fields, or Optune, or Novocure. There are different names for that. So this, again, Jay Zhu and his colleagues from Europe have tried this. This device actually was developed in Tel Aviv, or Israel. Basically provides 200 kilohertz of alternating electricity. Patient wear that on the head. We call it cap. So we tried that for. So this is the results that with the treatment. So they have TTF is 160 patients. Obviously, other patients may dropped out or whatever reason. So this was total censored or registered for analysis. And then the best physician chosen choice is 92. So for this arm, as you can imagine, they have all the other drugs before. They don't have to be the first recurrence. It can be the second recurrence or the third recurrence on this trial. So they have, this is a nitrosourea, which is a CCNU, BCNU, or the other drugs, PCV, is a combination of chemos. And then there's a platinum-based cisplatin, carboplatin, that's another chemo. And TFD is temozolomide, and CBT11, irinotecan, that's I was talking about, and then obviously bevacizumab. So the patient can get the previous treatment, can get the treatment, any of those physician choices, it's okay. And then the next slide is showing the results that the TTF group is slightly better in terms of the analysis of the results. And then the physician chosen choices is the partial response is only 7, and then versus the TTF is 11 patients. And then the next slide is showing the graph. This is the graph of the overall survival. As you can see, the red is the Novocure, and then this one is the best physician chosen choices, the blue. There's actually not a big difference. So that's the conclusion is the TTF is not better compared to best physician chosen choices. But they did a sub-analysis, which is tease out those patients not treating with the TTF according to protocol. So they are, as you can see, slightly better. Obviously, this is not the conclusion. The conclusion is this. But this gives the signal that the TTF might be as good as chemo alone, and then without other side effects, except the cosmetic one, without systemic side effects. So that's kind of the advantage. So then move forward to the next slide to a bigger trial, which is again Jay Zhu. That's what makes him so famous. So many different papers. He's the first author. And then they did it for newly diagnosed GBM, which I'm part of that trial in Boston, started 2009, and then carried forward to Texas. So this is the results. And you can see that with TTF, with plus standard of care, the patient is doing better. And this is standard of care only. And so that's the take-home message. The TTF is actually is good. And FDA approved this device last year. So we actually started using that for both recurrent and also newly diagnosed GBM. So next slide. So this is the patient. I call it NovoCure treated patient. So that's you can see the pre-op. Now you know before the surgery, the enhancement, and then the flare changes. Next slide. So this is after surgery, and then they still have the disease, but it's not growing. We call it stable. Next slide. So this is, again, with a contrast, as you can see. There's no contrast, which is good. Also, if you only see a line, that's okay. But as long as you don't see a nodular disease, that's good. And this is a flare change. And then keep going. So this is the same patient. It's from 2009 up to now. This patient is still alive, this GBM. And then this is a combination of treatment. So the summary is, for the standard of care of GBM, number 1 is surgery, number 2 is radiation, and with temozolomide. And now we added a NovoCure or TTF, but it's only starting that after the 6 weeks of the radiation, but you cannot wear that with the radiation, because that interferes with the radiation. But the radiation is done, patient can start wearing that if they wanted to. And then when they have recurrence, as I said, second surgery or SRS, that's stereotactic radiosurgery, and then bevacizumab. And nowadays, the bevacizumab have actually another trial that was just done for use for newly diagnosed GBM, and it turned out to be not as good. In other words, we used bevacizumab for the newly diagnosed GBM. On that trial, did not show any superior results compared to the control arm. So the conclusion is Avastin or bevacizumab used upfront is not better, because all the patients get the bevacizumab at the recurrence. And for the trial, that's the same kind of a design. When patients have progression, they are on the bevacizumab. So at the end of the day, compare the two groups, the overall survival has no difference. So that's where the bevacizumab status is. It's still useful, but it's not as exciting as it was before. And then so the new treatment is the NovoCure or the TTF. So what I've been doing is with NovoCure and then Avastin and the CPT-11 plus temozolomide. So it's 3 chemos plus 1 device. I think that's give us the best results. Obviously, if the patient's blood count is not good enough, you have to drop them, one of the chemos. But anyway, so for the patient can be motivated with using the device or a TTF, that definitely give patients additional options for control of the GBM. So next slide, I think that's it. So basically what I would share with you is GBM treatment is still very challenging, but we do see the hope of that. And then I think with the molecular medicine, we understand better about the single transduction, and then we have better drugs. The combination of therapies would give us the hope for control of the GBM for longer period of time. Thank you very much.
Excellent talk, my neurologist colleagues. Any questions? 3 questions?
Thank you. Great talk. I have 2 questions. First is from the molecular level. Can you explain, besides all the reasons you mentioned, why this disease is so hard to treat? Is there because it mutates or any other reasons behind it?
Yeah.
And the second question I have is about the treatment. Probably you mentioned already. You can put the TTS and then the Avastin and the temozolomide, and then also surgery, radiation. radiation and all that. Do you put all the modality together to treat it, or you kind of go one by one?
Yeah, so let me answer you the second question first. Yes, I use combinations. So it's actually in sequence. So for newly diagnosed GBM, surgery, and then you have radiation, temozolomide, and then when the patient agreed, they want it, we all offer them to the TTF to them, but some patients refuse, that's their choice. If they willing, and they do the TTF, so I have radiation, temozolomide, and then after radiation, the 6 weeks, and then TTF with temozolomide for at least 6 months. And obviously we do MRI every 2 months. That's the standard of care. If the tumor progresses, then we have second surgery if possible, or stereotactic radiosurgery, and then afterwards I would have added Avastin, CBT11, and continue temozolomide, and then adding, and then continue the device or TTF, or add a TTF if the patient was not on it before. Your first question is a very good one. That's why they are so resistant to treatment. Number one is, as I mentioned, the heterogeneity. That we understand part of that and only on part of the tissue, not all the tissue. Number one, we cannot remove all the tumor anyway. So we have limited, we have a biased sampling in the first place. And then depending on the institution, depending on the tumor location, so we cannot even remove that. And then number two is, we're treating every patient with the same treatment. And then everybody actually have different tumor mutations, and in addition to their own heterogeneity within the tumor. So it's multiple levels complexity. We're not able to get to the bottom of that yet. We are obviously a lot better, but there's a lot of different gene changes that we only target one pathway. Let's say temozolomide, we all knew, is targeting the alkylation, the DNA replication part of that. But it's not able to target all of them, and then different timing of different replication. And then the CPT11 is targeting topoisomerase, again, DNA replication process. There is actually, you are right, there's mutations. As we all know, we are the tumor is part of our cells normally before. It's just when they lose control, they keep growing. So that's what we call a cancer and tumor. And then they part of us years ago or decades ago. And then part of us is, we call adaptation. And that's evolution. So the tumor cells, when you hit them with radiation, with temozolomide, they actually survive. Some of those survive, and those survivors actually gain some survival advantage through what? Through mutation. So they have actually new mutations, new changes. If we sample the recurrent tumors from the second surgery or third surgery, there's always new changes. The profile of the next generation sequencing changes. You are absolutely right, that's the cause of that.
Medical oncologist from New York. I sort of have a two-part of my question. First of all, in my limited 15 years practice, I never see one survival from TBM. I'm just wondering, I guess you're a neuro-oncologist, right?
Yes.
Yeah, I'm just wondering, are you doing a better job than us? So that's the first question.
I'm trying to, but...
Yeah, second question, I mean, Avastin is the recurrent sort of the only bullet.
Yeah.
We do see patients survive 1 year or 2.
Right.
But eventually everybody die.
Mm-hmm.
But compared to like breast cancer, lung cancer, we're doing so good.
Right.
And this TBM is very depressing, especially
Right.
you know, a specialist presentation, nothing new, nothing really good.
Mm-hmm.
Immunotherapy checking point has been all over the place. You didn't mention anything about that, so I'm just wondering whether anybody tried. Because melanoma, immunotherapy is very good. So immunotherapy can go to brain very, very easily. My question, are we having trial, or why we relate in this field?
Yeah, so immunotherapy, I did not touch on that, which is, you're absolutely right. It's very exciting as well. Like the Avastin, for brain tumors, actually we did a trial with Opdiva, the nivolumab was done not by me, but David Reardon, his colleagues in Dana-Farber and other colleagues, for recurrent GBM versus Avastin. Did not work, not better. And then Keytruda of PAN trial is pending. Actually, another trial right now is ongoing. Mark Gilbert used to be at the NSC, now is the NCI, leading the trial, RTUG, with
Opdiva with nivolumab. So far, right now, is, as I said, results pending. So from my perspective, as you said, it is depressing, and we feel that kind of a depressing mood every day. So I'm trying to do a better job with my colleagues as a team. So one thing is a positive attitude for our patients, as I told you before. Patients are really literally shocked when they have this diagnosis, and then if you tell them the statistics, they cry right in front of you. The whole family is crying. And then the question is how to get them out of this, we call it litter, or depressed mood, to get them more motivated. As we all know, if you're motivated, things will be better. Even though it's not a cure, but it can be a better outcome compared to you are not motivated for anything in life. So that's part of my job, is to motivate them as much as we can. At the same time, to realize the challenges we all face together. And obviously, we try to do the better care in terms of be available and communicate with survival, but in general, in my practice, I try to push the limits. So I use this triple chemotherapy up front instead of doing that, or you try this one first, and this does not try this one. Once you try it, later on, the resistance, as we just discussed, gets more and more. It's harder and harder to treat. You might just treat it early, more aggressively. But yes, you have to be monitor patient, because more aggressive therapy has more side effects. So I have more responsibility to monitor them closely. And the patient obviously aware of that challenge as well.
So what glioblastoma has been moved to an adjuvant setting, combined with chemo, with a lot of success, and also radiation-triggered immunotherapy. So I think TBM is so depressing, maybe you should consider move this immunotherapy combined with chemo and radiation.
Yeah, we are trying to do, but one of the challenges, as we're doing the trial setting, right, you cannot get the drug. I mean, I prescribed so many times with nivolumab. Insurance will not cover it. So I appeal, reappeal. It's like a losing battle against the peer-to-peer conversation. I'm sure you all knew that. We're trying that, but in the trial setting right now, it's ongoing, as I said. We are looking forward to the results. Thank you.